There's not much controversy over in young patients whether you should fix these, so we don't really have to go through the literature. None of my disclosures mean anything today. We can just talk, I can just really talk about my approach because I don't have to go through a randomized trial to say you're going to fix intraarticular fractures in a young patient. Anatomy and biology are important. The anatomy is a little tough to see. Everyone relies on CT scans that they get before the OR, but it's really important to be able to identify the anatomic landmarks in the OR to find out or to determine that you're actually doing a good job of reducing this. So the landmarks are there, you have to look for them. I think the lateral is really important. We did some papers on the PUDA. We could talk about that separately. I'm not going to really talk about that today, but getting that restored is important if you're doing elbow fractures. But I think an important view is this one. It's sort of an oblique view in the operating room. And when you have your fixation in, to do this, because you should have these three lines, which are really the capitellum and the two columns of the trochlea. And if you don't have those three lines, you haven't reduced it adequately. And it's important in the part of the algorithm where you're looking at missing cartilage or if you're putting some missing bone together. The anatomy is fairly simple. It's a triangle at the end of the humerus. People think of the line between the capitellum and the trochlea as being the center of the elbow. It's not. The trochlea is the center of the elbow. It's just off lateral. That's important when you're restoring it. And the fact that there is a 4 to 8 degree angle on both the coronal and sagittal views that are important when you're reconstructing. And if you get those right, usually you can get elbow range of motion back together. Surgical fixation is really your choice. I mean, some plate systems are orthogonal, some are parallel. There's a lot of talk about being parallel being better because you can intertwine or interdigitate the screws distally in these complicated fractures. I think that is important. You can see in the upper right-hand side. But you can do that with either orthogonal or parallel plates, depending on the system you have in your hospital. You just have to figure out how to do it. So we're going to talk today about the complex fractures, not the simple ones. We're going to talk about these type of fractures that you see that are kind of displaced. This one has bigger pieces or smaller pieces, but a little more complex. I think of them not in a normal classification system. I think of them as in these 5 categories, in that all the pieces are fairly easily reducible. If you, in your mind, you can get them together with K-wires and put something on them. Some bone missing, some cartilage missing. Sometimes you have no cartilage, you can't identify it. And then sometimes you can't even see whether it's an elbow or not. So we're just going to go through my approach to those 5 kind of fractures. And if you look at these, I'm going to talk about approaches and what to do with those pieces. So your implant that you use, and you should have more than one implant system available, including an elbow arthroplasty system for some of these complicated fractures. You just really need to have something you can put in where you can get early range of motion. You're already battling a joint that wants to be stiff. You know, we're no longer brachiators, we're not climbing the trees. Your body just says, okay, I'll make it stiff, we'll be okay. So you want to get early range of motion, whatever you do. There is some evidence, though, coming out of the British group, that you can immobilize either in a cast or an X-fix for 2 to 4 weeks without much harm to the range of motion. And for these patients, a bag of bones is not really important. I'm going to talk about this afternoon. I've been doing these operations a long time. I taught myself an approach where I wouldn't have to use an osteotomy of the olecranon at any time. I haven't done one basically in 30 years. I find that when you do that osteotomy and put the hardware in, you have a lot of unhappy patients. About 44% of the patients have to have it removed in the literature, and it makes it hard to do a revision total elbow. So I try never to do it. I know I never should say never, but I never do it. My positioning for all these fractures is lateral decubital, prone as possible. If you're in a polytrauma situation, you can do it in supine. I've done it in every position, but I like to do it in prone. I like to have the arm hanging over a post. I like a sterile bump in case I have to revise the total elbow, because I usually shotgun my total elbow in. I don't put them in separately, so I'd like to be able to move the arm in a more radical fashion. I do a midline posterior skin incision for most of these. And the reduction does seem to influence the outcome, so you should be happy. And if you have a good reduction, that depends on a lot of factors, including bone quality. This particular group of patients have all got good bone quality. We're going to talk about geriatric fractures this afternoon. There's many different exposures, and you can do what you want. I use one in particular most of the time, but here are the exposures. Tricep split lets you get to most of them. I use the trap flap almost uniformly for any complex intraarticular fracture, mainly because I like the fact that the anconia stays intact because the innervation of blood supply comes through the triceps, and you don't have as much complaints about hardware prominence after you're finished because the muscle is over your hardware, and the patients are a little happier. If you're going to do a total elbow, I usually do it through a more medial approach. Dr. McKee said yesterday he does it through a tricep split as well, but I haven't done that. And then you can do an electron osteotomy if you want. The osteotomy kind of sacrifices the anconia, so you do have more prominence. That's why I don't like it, as well as the hardware. So for these pieces that are easily reducible, it's simple. You're going to do a split or a paratricipital. You have a fracture that looks like this. Those are all big pieces you can identify. You can say, okay, if I just tease those in place and hold them temporarily with the K-wire, I can do it. I don't have to be in the joint if I don't need to be, so that a patient would benefit from that and that they're not as stiff, right? So you kind of, this was done paratricipital. You can do it with a split if you want. They're the same thing. If you can actually get to the intraarticular section with the paratricipital, if you slide down and take that lateral portion off of the olecranon. The patients that have some bone missing or some cartilage missing are a little more complicated. You want to see inside the joint, so I usually use trap flap for those. And remember, I said you'd like to do this oblique view during the OR to make sure you have the reduction correct. So these are the patients with a little bit of bone missing. Remember, the angle has to be restored. Even if that bone's missing, you got to think of the 4 to 8 degree angle. So I usually do these with some kind of bone augment. I usually use a lot of allograft. You can take the end piece of the olecranon and use that if it's small enough missing piece, but I usually end up using some kind of allograft for these. I usually do it through a split or paratricipital incision. Here you go, young patient. Fairly big pieces, but when you get it together, there's a piece of bone missing. You can see I've got a clamp on a piece of allograft that I needed to reconstruct that to get the angle correct. And you put your plates of fixation of choice on there. This is the system we have in our institution that I tend to use all the time. There's a patient, an 8-year follow-up. The olecranon fossa is closed a bit, but it's good range of motion, so it's not really a problem. The approach for these patients with bone missing, cartilage missing, or can't find the cartilage is a trap flap. I'm just going to discuss that in brief. You can learn this. I didn't get taught this during my fellowship. It didn't exist. I learned this afterwards because I didn't like the hardware issues. So it's a flap through a posterior approach. You keep the triceps and anconius together. You come down and you trace that muscle belly of the anconius down. It takes about 15 centimeters down the olecranon, and you lift it as one piece. You preserve the MCL and LCL when you come in, and I repair it at the end through 3 fiber wires. You do an osteotomy. You can see right here the head is up here. This is the elbow down here. I think I have an X-ray with that. That's the elbow reconstructed. You take the end of the olecranon off, and you can imagine this is in 90 degrees. If you flex them, you can see about 100% of the joint when you do it, so it's kind of nice. There's an extended trap flap approach, which isn't really written up, but I use. So if you look at the LCL and you come around the corner and you can expose the entire distal humerus, but you want to get to the front, you just take the LCL off, and you can actually book open the entire humerus, and you can see the front and back at the same time. So it's a really useful way to get to the entire joint. Let's say you have some cartilage missing. You can use whatever classification you want, but you just have to recognize what piece is missing and where they go. And this is the normal fracture pattern, and these pieces might be in disparate places. It might be 2 centimeters up the humerus when you go in, but you got to recognize where they go. So how do you hold these? It's really hard to hold these. I recognize that. So here's a typical patient right here. I've kind of put it together with multiple K-wires, and I'll show you how I do that, and then kind of put the fixation on when you have that in place. So what I do is I start with K-wires. I cut them off a little proud so the next piece goes on the K-wire, and it sticks there. And that way, you kind of got stability, and then you just keep pinning those in place and keep doing the same thing. And you end up with a bunch of small K-wires inside the bone that'll never come out. You've just got to accept that. But if you use 0.8 millimeter K-wires or less, you can actually drill through them with your fixation. So it's okay to do that. And you just keep doing that across and then put a bunch more in. This is sort of what it looks like at 6 years. Had a bad injury, had some heterotopic ossification, but really was fairly happy with their follow-up. Dermoplasty is my option for the young patient if that fails. If that patient came back 6 years ago, my elbow's not working, I'm a roofer, I need to do something, but I haven't done very many of them. I've done a few of them. Don't do what they do in the literature. They say take a piece of dermis from the leg, take it from the abdomen. It's really easy to close that way. What can patients, as you kind of come in and say, maybe it's an elbow, maybe it's not an elbow. Here's a polytrauma patient, obviously has a lot of things going on, but if you look at the elbow, there's not a lot of elbow left. Osteotomy in this patient's already done, so I don't have to worry about the trap flap. But you just have to, it's a bad day, you know, you just kind of get at it and you kind of get it done. And it takes a while, but there's no one standing behind you going to redo it. Your best chance is the first time. So if you're going to undertake this, just realize you're going to spend a few hours putting this all back together, but it's possible. And then the other last option, is that an elbow at all? I mean, it might have been an option for that last patient to say, oh, I'm going to do just total elbow on that, but that patient's 38 or something. You don't really want to do that, right? So if it's an elbow, my approach is medial mori. Generally, you can do with tricep splitting if you're doing an allograft. I have done a fair number of allografts. This is a patient that came in, seen elsewhere, and there's really no other option, a young patient for me at this time, than to do an allograft. I mean, you're obviously going to refer that on, but that's the option I see in young patients now. And then the other patient, is this really an elbow? So somebody tried to fix this at an outside hospital and sent to me, looked like this. In my hands, I can't fix this, okay? So I just said, even as a young patient, I just said, okay, I'm going to do a total elbow. The problem is they don't really last. Although last week I did book one 28 years out, finally wore out. So in my mind, 5 to 8 years is all you get from this Kunrad-Mori elbow, but that patient got out 28 years, and I'm going to revise it. Anyway, thanks.